Okay, Chapter 13, Medication Administration. It's about 107 slides in this particular set, and my hope is that we can get through this all in one sitting. And I know Chapter 14 has over 200 slides, so we'll probably break that up into perhaps two or three sessions. So if I can get this to advance, then there we go, and we'll move right on through this presentation. All right, learning objectives. We hope to list the basic mathematic principles concerning paramedic pharmacy stuff, review the mathematic equivalents, differentiate temperature readings between Celsius and Fahrenheit, discuss formulas as a basis for performing drug calculations, discuss applying basic principles of mathematics to calculation of problems associated with medication dosages, and discuss the legal aspects affecting medication administration, discuss the 6 rights of drug administration, discuss medical asepsis and the differences between clean and sterile techniques, describe the use of standard precautions when giving medications, describe the use of antiseptics and disinfectants, describe the disposal of contaminated items and sharps, describe the different oral dosage forms, general principles of giving oral meds, describe the technique and general principles of rectal medication administration, describe the technique and general principles of giving medications through a gastric tube, describe the technique and the general principles of giving medications topically, giving medications by inhalation route, talk about withdrawing medications from an ampule or withdrawing them from a vial, as well as describe the technique and general principles of giving medications by the sub-Q route, by the intramuscular route, and then talk about the equipment needed and the techniques used for peripheral venous access, as well as intraosseous access, and then some equipment needed and techniques used and complications and general principles of obtaining a blood sample. Now, drug dosage calculations. There aren't many drugs that as a paramedic you're going to have to calculate. There are a few, and we'll certainly be well versed in those by the time we get through the program. But one of the challenges we have is that when we learn our weights and measures, we learn from the apothecary system, which is ounces and pounds, and we have to convert that to micrograms, kilograms, and grams. We learn ounces again, and we have to convert that to milliliters, deciliters, and liters. Those sort of things. So the apothecary system looks at the grain weight, and it's based off the fact that 1 grain of wheat equaled 1 unit, and 1 ounce was 480 grains of wheat. 1 pound, or 12 ounces then, would be 5,760 grains. Now, there's not anything that we do in grains anymore. Back in 30, 40 years ago, physicians would order morphine in grains. So you had to be able to convert grains to pounds to milligrams. So it was a little more complicated then. The apothecary system looks at the linear measurement of inches, yards, and miles. It looks at volume as minims, fluid drams, ounces, pints, quarts, gallons. When we're dealing with quantities less than 20, we use a lowercase Roman numeral. When we're dealing with quantities greater than 20 in the apothecary system, we use Arabic numbers and fractions. In the household system, which is apothecary, we've got the dropper, the teaspoon, the tablespoon, the cup, the glass, the pint, the quart, the gallon. Now, the metric system, which is how we base the administration of drugs on, their weights in the metric system is all based off units of 10. So they've got grams, milligrams, micrograms. With length, you've got meters, With volume, we're dealing with liters and milliliters and microliters. And if we look at the pharmacology mathematic equivalents using the metric system, centi is 1/100th of something, milli is 1/1000th of something, micro is 1/1,000,000th of something, and kilo is 1,000 times whatever the basic unit is. So 1 gram would equal 1,000 kilograms. When we look at metric conversions, and this is where we have to convert. Mostly when we're dealing with math, in our situation, we would be converting grams to milligrams or milligrams to micrograms. So when converting grams to milligrams, you just multiply the grams by 1,000. When converting milligrams to micrograms, you move the decimal 3 places to the right. When converting milligrams to grams, you're going from a smaller number to a larger number. Divide the number of grams by 1,000 or move the decimal point 3 places to the left. And you can see that if you divide by 1,000, there's 3 zeros there. And if you remember that a milligram is 1/1000th of a gram, that's 3 zeros. If you have 1 milligram, you just move that decimal point 3 places to the left. Also with the metric system, we have to convert temperature. We learn everything certainly in Fahrenheit, but much of medicine discusses temperatures being displayed in Celsius. Where we see this is when we talk about therapeutic hypothermia in advanced cardiac life support courses. The therapeutic range for hypothermia in adult patients is 32 to 34 degrees Celsius. Well, unless we have a smart app or unless we know the formula here and do the math, it's a little different as to what that is on the Fahrenheit scale. So to go from Celsius to Fahrenheit, you multiply Celsius by 9/5 and then add 32. To go from Fahrenheit to Celsius, you subtract 32 from Fahrenheit and take it times 5/9. When we're looking at milliliters and cubic centimeters, those two terms, mLs and cc's, essentially are the same. Milliliters and cubic centimeters is 1/1000th of a liter or 1/1000th of a meter. We get away from using 1 cc. We don't record milliliters as cubic centimeters anymore because with sloppy handwriting, a 1 cc could look like 100. So we use 1 ml. We don't use the cc anymore in our documentation. We use ml. Weight conversions. There are times where we are going to have to convert our patient's weight in pounds to kilos. And just remember that, to convert pounds to kilos, just divide pounds by 2.2. And then to go back, which I'm not sure why you would need to, you could take kilograms times 2.2 to get pounds. Now, there's several different formulas that are used when doing drug dose calculations. And this first formula is where we will take the desired dose times the volume on hand divided by the dose on hand. And that will tell you how many or how much liquid you need to administer out of that particular pre-filled syringe or out of that particular vial. You could see that, as an example with that diphenhydramine, there's 50 milligrams per 1 ml, and there is 1 ml in that vial. So there's 50 milligrams in that vial. If I wanted to give 25 milligrams IV, we could take 25 times 1 divided by 50, and that would tell us how much liquid to give. So 25 divided by 50, we would have to give 0.5 mils. With formula number 2, that's just determining drip rates. And to determine a drip rate, you just take the desired dose of liquid, the desired dose of saline, the desired dose of D5W, whatever, times the property administration set, whether it's a 60 drop ad set or a 10 drop ad set, and divide that by total time in minutes. And that's going to tell you what to set your drip rate at. Another formula that we work with is how to administer drugs based on weight in kilograms. So the first thing we have to do is calculate the patient's weight in kilograms by dividing their pounds by 2.2. Then the second step of that formula is to multiply the kilogram weight by the desired dose that we're supposed to give. To prepare the infusion, calculate the dose you have on hand or the concentration of what you have on hand, and then you set up a ratio, and you cross multiply and divide to solve for X, and X will be the amount of liquid that you have to give. Here's an example of using that particular formula. Let's say a doctor's ordered you to start a dopamine drip at 5 mics per kilo per minute in this 220-pound patient. What would you set your drip at? Well, the first thing you have to do is convert 220 pounds to kilograms. So we divide 220 by 2.2, and that gives us 100 kilograms. So we have this 100 kilogram patient, and the doctor's ordered 5 micrograms per kilogram per minute. So the second thing we need to do is determine our rate of infusion. So we take our 5 micrograms times our 100 kilogram patient, and we have to give them 500 micrograms a minute. That's our infusion rate. And then we have to determine our dose at hand. Now, dopamine comes standard as 1,600 micrograms per mil. And if you remember when we did some of the drug calculations on the board, I showed you the clock method, I showed you other methods to help determine your infusion rate. The fourth step is to set up your ratio and cross multiply so that you can get X all by itself. So we know that we have a 1,600 mic per mil concentration, and we also know that we have to give 500 mics. How many mils is that? So then we cross multiply and end up with 1,600x equals 500. To get x all by itself, we have to divide both sides by 1,600. And that leaves us with x equals 31 mils per minute. 31 mils per minute to get our 500 mics per kilogram, 500 mics per minute. As far as medical direction goes and the administration of medications as a paramedic, some of the legal considerations that you have to think about include, federal laws, certainly governing controlled substances, state laws on the storage and transportation of medications, local laws, perhaps city ordinance, those sort of things, governing the purchasing, the distribution, the dispensing, and the administration of drugs. When we're entrusted to carry medications that in the wrong hands certainly could be lethal, when we're talking about higher doses of controlled substances, when we're talking about paralytics, those sort of things, the regulations concerning the distribution, dispensing, and administration of these drugs require us to be very familiar with the laws, but also do things like counting the drugs every shift, do things like accounting for the drug kit, that it's not been opened or has not been tampered with, And then when it comes to administering the medications, certainly with controlled substances, we often have to get a physician's signature on the back end after we've administered the controlled substance, and anything left over has to be wasted and in the presence of two people, so that you have witnesses that the medication was wasted rather than given to an individual. And typically when we waste a medication, we just squirt it down the sink and then run some water down and that sort of stuff. And when it comes to, the type of drugs that we carry and how they're dispensed and the doses that they're administered in, we've got some standards of care. We've got some protocols that are accepted on certainly a federal and state level, but essentially the medical director has the final word on that, because you are, in fact, working under their license. So that's where our protocols come in. They can be written, they can be online. Certainly written protocols are filed with the State Board of Pharmacy. Online protocols, we may, let's say that we want to, let's say our protocol says that we can administer 3 doses of nitroglycerin, so many minutes apart. And it's working for us, and we're still not back at the hospital, and we want to give some more nitroglycerin. Well, even though our protocol says we can't, we might want to call into medical control and then follow, get their approval to continue to administer nitroglycerin. And certainly, if we can't get a hold of medical control, then we have to fall back on what it says in our written protocols. And if there certainly is an event that occurs and we don't have a protocol for it, we've got to get medical direction before we can proceed. And medical direction protocols for the service certainly differ among EMS systems depending upon your scope, but also depending upon what your medical director wants you to give. Some principles of medication administration include certainly, the safety considerations and procedures, like you being very familiar with the drug, the indications, the contraindications, the side effect, whether or not you require a physician's order to administer the drug, and if so, how do you verify that physician's order? It does require you to concentrate on the task. In a pretty high-stress situation, it's very easy to make a tenfold error by inappropriately moving the decimal point one way or the other. The patient has to be properly positioned. You have to assemble and use all the correct supplies and equipment. You have to handle the drug carefully. If you're dealing with glass vials, if you're dealing with glass ampules, those sort of things. We have to practice aseptic technique, and we'll talk a bit about that as well. And carefully calculating the drug doses. Pretty much anymore, you might have to bounce that off a second person if they're available. Let's say that you've got to give 0.5 milligram of atropine, and you have 1 milligram in 10 mLs, and you do the math and figure out, for me to give 0.5 milligram of atropine, I need to give half of that 10 ml. And you may verify that with your partner, so that when you do push the medication, you're confident that that's the right dose. If we're giving drugs in IVs that contain drugs, or if we're pushing one drug and then immediately following it with another drug, we have to make sure that our drugs are compatible. Because if they're incompatible, usually the worst thing that can happen when they're incompatible is that one will render the other one ineffective. You got to monitor for signs of overdose and take corrective measures. And where we're going to see this certainly is if our dose is incorrect, and we made that error, that tenfold error by the movement of the decimal point in the wrong direction. That certainly can lead to an overdose. But we often will see overdoses when we give normal doses of medications to people in liver failure, or normal doses of medications to people over the age of 70, or patients who are in shock. Those patients, we really should consider giving half of the normal IV dose. And it's important that when you do give the drug that you document what the drug was, what the dose was, the time you gave it, the route you gave it, and how the patient responded to it. I've heard of 4 rights, 5 rights, 6 rights, but this program talks about the 6 rights of drug administration. You have to make sure that you have the right drug. You have to make sure you have the right patient. You're giving the right dose at the right time through the right route, and then the right documentation. The right drug can be a challenge, particularly if they're sound-alikes or they look alike in the way that they're packaged. So you got to make sure it is the right drug. As an example, sodium bicarb and D50 laying side by side are difficult to differentiate. Same thing with atropine and epinephrine. When they're laying side by side, it's difficult to differentiate one from the other. The right patient usually isn't an issue at EMS because we're only dealing with one patient that we're giving this medication to. The right dose, that's something that we have to be certain of, because again, a tenfold error can be quite easy. Right time, if we're administering medications every 3 to 5 minutes, then it certainly is important that we do that. The right route, if the drug is only to be given IM and we give it IV, that could be detrimental. And then the right documentation. Medical asepsis for us just means that you're medically clean. It's very hard for us in a pre-hospital environment to practice aseptic technique because we're not back in an OR. We're in some pretty hostile, uncontrolled environments, and we certainly do our best to keep the sites clean where we're starting IVs, to keep the injection ports clean, those sort of things. When we don't practice medical asepsis, certainly that ends up being a source or a site for infections that could lead to sepsis. Whenever dealing with medication administration, because you may be poking a person with a needle, because you may be withdrawing that needle, and if it isn't sheathed quickly, there's always that potential, especially bouncing down the road in the back of an ambulance, of poking yourself with it. So standard precautions, wearing gloves, certainly hand washing before and after touching the patient is important as well. Antiseptic versus a disinfectant. A disinfectant or disinfection is the process of cleaning the vehicle, the stretcher, the equipment. And an antiseptic is the process used to clean the skin before you puncture with a needle. Now, there's 3 or 4 different types of antiseptics that people are putting on skin prior to starting the IV, so you'll just use whatever your service uses. Sterilization. Sterilization makes the object free from all forms of life using extreme heat and certain chemicals. And then sepsis is an infection that can result as because of non-compliance to aseptic technique. Certainly medical asepsis includes proper drug handling, how we store the drugs, how we handle them. Our narcotics and our controlled substances need to be double locked, and how we care for the site. Prior to injecting anything or screwing anything into an IV port, it's important that we clean the port with alcohol. Same thing with the skin. Prior to starting an IV, prior to sticking it with a needle, we need to make sure that we make the skin as aseptic as we can so that we don't introduce a microorganism during the puncture that could lead to an infection of the IV site. We don't recap needles, and certainly it's not anything that we recommend happen. Oftentimes in the back of the ambulance there's a sharps container on either side that is within reach, and certainly if there isn't a sharps container, we don't just throw the needle down on the ground or stick it into the seat so that it doesn't poke anybody, but does poke a hole in your nice seat. but Chapt should go in a Chapt container. Don't overfill Chapt's containers. Chapt's containers, once they reach about 3/4 full, they should be emptied and changed. They should not be put in with the regular trash. They need to be handled, hauled away and incinerated. And make sure that all Chapts are accounted for before moving the patient from the ambulance. Enteral medication administration is to give oral meds. Enteral medication administration would include some sublingual meds, and those are meds given under the tongue. And you do that with gloved fingers. These pills given under the tongue, they're not swallowed, they're not spit out or rinsed. Certainly the advantages of sublingual medication administration is the rapid onset. And the most common drug that you're going to give sublingually in the pre-hospital environment is going to be nitroglycerin. You're going to, when giving a sublingual medication, you're going to place the pill under the tongue and tell them not to swallow, not to spit out or rinse, and let the pill slowly dissolve. Underneath the tongue, is quite vascular, and it's a good place to go to quickly get things into the bloodstream. If you're using the nitro spray, and a lot of people use that because it's so much easier to handle than little tiny white pills, don't shake the container. Hold the container upright with the index finger on the top. Place it close to the mouth without touching the mouth. Have the patient stick up their tongue and squirt the nitroglycerin under their tongue. Giving buccal medications, this is where we would give glucose paste between the cheek and gum. And really the correct way to give buccal medications is to take a tongue blade and smear some glucose paste, and then take that tongue blade and slide it in the side of their mouth where the glucose is rapidly absorbed by the mucosa in the mouth. And we can use the buccal medication administration route for a conscious diabetic that can swallow and their sugar's low. Rectal Valium is an enteral route, but instead of giving it PO per oral, we're going to give it PR per rectum. To give rectal Valium, particularly in children who are having seizures and it may be difficult to establish an IV, place the child on their side facing you, measure for weight using the length-based colored tape. That's going to tell you how much of the drug to give. Open the package to remove the syringe, remove the cover, lubricate the tip, bend the child's upper leg forward so the knee is close to the chest. Expose the rectum by separating the buttocks. Insert the lubricated syringe tip into the rectum. Slowly count to 3 while you push the plunger and push all your medication in, and then slowly count to 3 before removing the syringe and plunger. By doing so and holding the child's buttocks together will prevent the leakage of the rectal Valium, and it'll be absorbed quickly through the mucous membranes. This certainly is a route that we would take if we had a child in status epilepticus and we needed to stop the seizure. Enteral medications through a gastric tube. A gastric tube could be OG, oral gastric through the mouth, or NG, nasogastric through the nose. Nasogastric tube insertion is certainly something that if you work in a facility is something that you might do. It's not likely anything we're going to do pre-hospital, but you place the patient in a sitting position with a stretcher at 45 degrees angles. The head is at 45-degree angle. Give the patient a cup of water with a straw. You're going to measure the tube, and you want the tube to end up in the stomach. You measure the tube as they're doing in step, the first picture and the second picture. They're measuring the distance back and then the distance from the angle of the jaw into the lungs. Mark the tube so you know how deep to insert it. Prep 2 to 3 inches of the end of the tube with some water-soluble gel or lubricant like KY jelly. Have the patient tilt their head forward and sip the water through the straw, asking them to swallow. Now, as they swallow, slowly insert the tube into the nostril until you reach the pre-measured mark. If you run into resistance, don't advance the tube. You can withdraw it and retry, but if the resistance continues, then attempt another nostril. Verify tube placement by injecting about 20 milliliters of air into the tube while listening over the epigastrum with the stethoscope, and if it's in the correct place, a rush of air will be heard, and you can tape that tube down in place. Parental medication administration, some topical meds. Things that you can give on a patch might include nitroglycerin, fentanyl, estrogen, nicotine. All those are parental medications that you could give through that would absorb in through the skin. Giving inhaled medications like a meter dose inhaler directly disperses the measured dose of fine spray into the airway, and if the patient is breathing normally, they certainly can benefit from that. To do a meter dose inhaler, prep the patient by having him sitting up, assemble the inhaler, add the spacer if it's something they got, grab your mouthpiece, shake it, shake the inhaler to mix up the medication, and then position the mouthpiece about 2 finger widths from the mouth, and if you're using a spacer, have the patient close their lips around the spacer or around the, if you're not using a spacer, around the mouth of the meter dose inhaler. Ask the patient to inhale deeply and exhale, and then inhale slowly while the inhaler is activated. Have them hold their breath for 10 seconds and exhale through pursed lips, and then observe or document the procedure. Now, this can really be difficult in a person who's extremely short of breath. They may not be able to take a very deep breath when you give them a puff of this, and they may not be able to hold their breath for a full 10 seconds. What works better, certainly, and can be done as a paramedic, is a small volume nebulizer. So if you carry one of these small volume nebulizers, that's great. Otherwise, some of your small volume nebulizers just plug right into an oxygen source in your rig, and the drug is aerosolized in the bowl and then is blown out as a mist through the tube. Once you've got that done, you're going to attach the T-piece and attach the pipette and the spacer for the small volume nebulizer, unscrew the cap, fill it with, fill your bowl with the medication that you're going to use, the bronchodilator, and typically it already comes diluted. There are times where maybe you have just the straight medication and you have to put so much of that in there and then add 2.5 mils of normal saline, but pretty much in all your meter dose inhalers or all your small volume nebulizers, your albuterol comes pre-measured in a single dose packet. Attach the cap, shake to mix the medication, and diluent if you had to do it that way. You don't have to shake it if it comes all pre-mixed for you. Attach the oxygen supply, attach the cup to the bottom of the T-shaped piece, adjust the oxygen flow rate to 6 to 10 liters per minute to create a fine mist. Have the patient sitting up, and if they're able, hold the mouthpiece in their mouth and have them inhale slowly, hold it for several seconds, and then exhale through pursed lips. And keep doing this until all the medication is gone. We can give certain drugs down an endotracheal tube, and those include lidocaine, atropine, Narcan, epinephrine. Another acronym is NAVAL, which includes Narcan, atropine, Valium or vasopressin, epinephrine, and lidocaine. So those are the drugs that we can give down the tube. The onset can be rapid, but the action is unsure, or the onset can be rapid. But the amount of drug that crosses the alveoli and gets into the patient's lungs, we've got no real good way of measuring that. It's certainly important to remove the needle from the syringe before instilling the medication in the ET tube. You know, if you're, most of our systems are needleless, so it's not like we have to take the needle off the syringe unless we had to draw the medication up out of a vial. If it comes in a pre-filled syringe, then you know, there shouldn't be a needle on it, because pretty much all our systems are needleless. The thing about endotracheal medication administration is that you have to give 2 to 2.5 times the IV dose, and that could be a lot of liquid in some patients. So here's the steps to do that, and certainly in your labs you'll practice these drug administration techniques. Ventilate the patient's lungs several times with a BVM. Disconnect the oxygen source from the ET tube. Squirt your medications down, and then continue ventilating the patient to dispense the medication. Now, you can give intranasal medications as a paramedic, and often they do require larger doses as well because of just how they're absorbed. You know, the mucosa in the nose is quite is full of lots of blood vessels, and absorbs the medication, and it quickly gets into the bloodstream when given intranasally. But there's not, you know, you can't give all meds intranasally, but certainly some of the more important meds like Narcan, there's intranasal fentanyl, intranasal ketamine, you know, so there's a variety of medications that we can give intranasal. I know they're working on an intranasal insulin, which would just be awesome if that happened, and it would eliminate people having to give themselves shots. Which leads us to injectable medications. In order to give injectable medications that you're going to actually inject either intradermal, sub-Q, or IM, it requires you to have a needle and a syringe. Syringes come in a wide variety of styles, from a tuberculin syringe, which is graduated in 1/100ths as far as their measurement goes, all the way up to a 3 milliliter syringe, you know, all the way up to a 50 milliliter syringe. Sometimes the syringes come with a needle already attached to them, and that needle will have a protective sheath over it that you can replace back on the needle when you're done with the procedure. Injectable medications, you know, some parenteral medication containers that you're going to work with certainly include things like the pre-filled syringes and the vials and ampules. When you're withdrawing medication from an ampule, some of the medication ends up in the head. The neck is the narrow part, and it has a scored line around the neck, and that's where the amp is going to break. But before breaking open the ampule to draw the medication out, you need to tap the head of the ampule to get any medication that's up there down into the body of the ampule. Swirl it around if that's what needs to be, and then using some sort of 2x2 or something like that, you can grab a hold of the head and snap the ampule at the neck. But do understand now you're dealing with several pieces of perhaps sharp glass. I myself have never been cut by the glass of an ampule, but there certainly have been people who have. Tap the syringe to remove or draw the medication out of the ampule into a syringe with a needle. Tip the syringe upright, adjust the plunger to get most of the air to the top, tap the syringe to get all the air out of the liquid itself, and then push the plunger until the medication slowly dribbles out the needle. When you're withdrawing from a vial, the thing that's important here is that you have to prep the head of the vial with an alcohol swab, and then you have to inject the amount of air into the vial equal to the amount of liquid that you're going to take out. So you got to put the amount of, if you're taking 2 mils out of that vial, you have to put 2 mils of air in there. And this helps create a pressure inside the vial that allows you to draw the medication out. If all I did was continually just draw medication out without putting any air in, I would suck all the air out of the vial and create a negative vacuum that wouldn't allow me to draw medication out of the vial at all. So here, tap the syringe to remove the air bubbles. Push the plunger to expel the air till you get your desired dose, and then remove it from the vial, and then properly dispose of your sharps. Now, here's an interesting way to administer medications, and it's not something we do very frequently, and that's intralingual injections. Intralingual injections is an injection of a medication under the tongue, or at the base of the tongue. It requires you to use a 25 gauge needle, which is quite small, and then 5/8, which is, a little more than half an inch. And the two drugs that we can give intralingual include epinephrine or Narcan. With the advent of, our ability to give IM epi, our ability to give racemic epi through a breathing treatment, our ability to give Narcan through the nose, there just really has not been a reason for us to give this intralingual injection, but it is an option. When you're injecting medications into the body, there's those 4 different routes that you can use. Intramuscular is at a 90-degree angle to the body. The needle is long. It goes into the muscle tissue itself. Subcutaneous can be the same length needle as IM, but it's injected at a 45-degree angle to the body. It ends up in the subcutaneous tissue where your fat is. And then intradermal, that's at about a 15-degree angle. That's just under the dermis, just under that first layer of skin. And then intravenous is in a vessel itself. When you're giving medication injections, there's a variety of different sites that you can use to give the medication. When you're looking at sub-Q injections, insulin is something that we would give sub-Q. We used to give epinephrine sub-Q, but now that we're giving epinephrine in patients who are, might be a little shocky and their pressures might be low, we don't use this route anymore. We give it IM. The issue with sub-Q is that when you give the medication, it ends up into the fat. And the fat does absorb the medication, and when the fat is metabolized, the medication, gets used. But in states of shock, there's not much of a blood supply to the muscle, let alone to any fat cells. The maximum volumes that you can use in subcutaneous injections include 2 milliliters in adults and 0.5 to 1 milliliter in children. And again, we don't give sub-Q injections in a person with shock because there's just no circulation to the fat itself. To give a sub-Q injection, you're going to make sure you've got the right, do the rights. Select your site, cleanse the site with an alcohol wipe using a circular motion. Pinch the skin and lift the subcutaneous tissue away from the muscle. So pinch that skin, pull up a chunk of fat, insert the needle at a 45-degree angle with a darting motion. Release the skin, pull back on the plunger to make sure you're not in a blood vessel. And if there's no blood return in the syringe, then go ahead and inject your medication and then dispose of it properly in the sharps, and then observe your patient and document it. IM injections, that goes right into the muscle itself. It's a lot faster onset than sub-Q. And the only complication is, certainly depending upon where you inject in a muscle, you could cause some nerve damage. If you're going in the deltoid, which is, around the top of the arm, that's 0.5 to 1 milliliter of medication. If you're going into the glutes, either the dorsogluteal site or the ventral gluteal site in the hip, you can give, up to 3 to 5 milliliters of liquid in those sites. And the vastus lateralis and the rectus femoris sites, that includes the thigh itself, again 3 to 5 milliliters. So here's how to do a deltoid administration. You find the acromion process. The clavicle and the acromion come together along with the scapula to form the upper margin of the deltoid muscle. And so laying your hand across there and drawing this particular triangle, anywhere in that triangle is an acceptable place to give your sub-Q or IM injection. When we talk about the dorsal gluteal site, if you take the, certainly the where the cheeks divide and draw a line straight across that, and come out to the iliac crest and draw a line straight down, you can divide that into 4 quadrants that you see here. The upper lateral quadrant is the dorsal gluteal site, where you can administer the medications. Now, by far, most people use the upper medial quadrant to give their dorsal gluteal shots. They use that upper medial quadrant more towards the the very top of the buttock. You get there in where that center line is, and you get too low. Certainly, the thing to be concerned with there is that sciatic nerve, and if you were to strike that sciatic nerve with the tip of the needle, it could cause some intense, serious pain in your patient's leg and some permanent nerve damage. The ventral gluteal site, again, here they're showing you the landmarks for that, and anywhere in that V between the first and second finger, you could give your injection. The thigh, anywhere below the hip or above the knee, in that area there that's identified in the dotted line, that would be the vestus lateralis muscle and the rectus femoris muscle, and anywhere in there you could, either on the lateral side or on the top. If you give the injection on the top or the anterior portion, you're going into the rectus femoris. If you give it on the side, the lateral side of the thigh, you're giving it in the vestus lateralis muscle. IM injections, to do it properly, you're going to flatten the tissue out so that you can get to the muscle. You're going to take your 1.5-inch needle, 23, 24 gauge, 1.5 inch, prepare the site at a 90-degree angle on the flat tissue that you've flattened out, dart that needle in, bury it to the plunger, pull back on the plunger of the syringe, bury it to the head of the needle, and on the plunger of the syringe, pull back to aspirate to make sure that you're not in a vessel, and then inject your medication, and then pull straight out and massage the area when you're done. Now, some blood may come back out, so it's a good idea to have a 2x2 handy there when you pull the needle out. Getting vascular access to a blood vessel, we can do that through IVs, we can do it through venipuncture, and we can do, once we access a vein, then we can do intravenous therapy and administer fluids or administer drugs through an infusion. Peripheral venous access includes inserting a IV catheter into a vein, and what we see most often is saline lock, which is demonstrated in that very top picture. Rather than have an IV attached to it, rather than having fluid run into the patient when they may not need any fluid, just doing a saline lock and then flushing that with a little saline, that will stay open and won't clot for a period up to 8 hours. Now, we have three different types of catheters when we're looking at IV catheters as a paramedic. You've got an over-the-needle catheter, and that's where the Gelco or the Teflon catheter slides over the needle, and that's the most common type of IV that's out there. You've got a through-the-needle catheter, and that's where the catheter slides inside the needle, and the needle's on the outside, catheter's on the inside, and we see this with PICC lines, peripherally inserted central catheters, which may or may not be in your scope of practice depending upon where you work. And then you have a hollow needle, or what we call a butterfly, and those are popular for drawing blood through syringes in really difficult, tough sticks. When we're thinking about starting in a peripheral IV, some things to consider certainly are, why are we doing this? If it's to administer fluid and lots of it, the IV needs to be a large gauge. It needs to be in a large vessel. How much fluid are you going to run in? How much medication are you going to infuse? What's the condition of the vein? How easy is it to access it? How big is it? What sort of size needle can we put in it? What's the patient's age, their size, their general health? Are they left-handed or right-handed? Some people won't put an IV in the person's dominant hand because they move that quite more frequently and have a tendency to infiltrate those sites. Note if they have certainly any disease or certainly any injury or any prior surgeries. Look for a shunt or a graft that would indicate that they're on dialysis. We don't want to start an IV in a shunt or a graft. And those people who are good at starting IVs are people who start IVs. There's a variety of different IVs that certainly we can tackle in the arm, in the back of the hand, and they're all shown there. We can go down into the leg, but it's just not common or likely. I've started IVs in the feet before when we have really limited access anywhere else, but you can see there that you certainly could start an IV in the foot if it was available. Typically, we reserve those for children. One of the, probably one of the more, neat sort of IVs that as a paramedic you might get to start is a EJ, or an external jugular. This is a large vessel in the neck, and you can find the person's jugular vein by sitting them up at a 45-degree angle and having them turn their head to the side. The external jugular lies along the path from the angle of the jaw to the mid-clavicular line. So in that path, when you have them sitting up at a 45-degree angle, their head turned to the side, in that path you should be able to see jugular vein distension, particularly in a patient who is hydrated. It will become distended in patients with right heart failure. It will become distended in patients with tamponade as well. But it's often in cardiac arrest, very prominent, very large, and very easy to hit. We'll go through the process for peripheral venous access using an intravenous catheter. The first thing you have to do is assemble your equipment. So you got to spike your bag, have that all ready to go, and then you got to tear your tape or open up your whatever sort of opsite or whatever you're using to put over the puncture site once you get it done. Then you're going to put a tourniquet on and select the site where you're going to start the IV. And I think this is critically important to success, is making certain that you select a site where the vessel itself is easy to be seen or easy to be palpated, that the vessel itself is straight, that the vessel itself doesn't have valves. All those things make it very difficult to start an IV. Here they're saying with your non-dominant hand, anchor the vein by pinning it down with your thumb. And by pinning it down with your thumb below where you're going to start the IV, that prevents that vein from rolling from one side to the other when you go to make your poke. Okay? Make your poke, again, with a jabbing sort of motion, quick. And when you enter the lumen of the vein, you'll feel a pop. You'll see some blood return through the gelco into the collection chamber, and then remove the tourniquet, pull the needle out, and they often either are spring-loaded and self-sheath, or you slide a sheath up as you're pulling the needle out, and when you get to the end, you engage a lock that locks a cap over the end of the needle so that you can't poke yourself. Add to that your saline lock, add to that your intravenous administration set tubing, and then tape it all down and set your flow rate. To do a external jugular vein, the important thing here is that while it's a large vein, you're going to have them lying flat. You're going to turn their head to the side. You're going to isolate it, a nice straight piece of it there. And then you're going to do the poke towards the heart, not towards the top of the head. You're going to do the poke towards the heart, and that can be a little tricky. Back in the day, we used to have to bend our needle and gel coat just a little bit to get the right angle. But once you do the poke and you're in the vessel, you'll feel that give. Your IV catheter will flash with blood. But when pulling the needle out, it's critically important that we get that hooked up right away, or that we occlude that external jugular vein both at the insertion site and above the insertion site. That's a very large vessel, and as blood moves by that vessel, it can pull air in with it through that hole where the IV catheter is. So if you leave that and it's not hooked up, it can draw air into the neck and cause an air embolus. Central venous catheter is something that we do not do. Central venous catheter is something that a surgeon does. They insert a central venous line into the vena cava through the subclavian vein, through the internal jugular, or through the femoral vein. And they'll do central venous catheters for long-term IV therapy, if they're going to be giving large volume loads, if they're going to be giving lots of blood products, hypertonic solutions, caustic medications, caustic antibiotics, if they're going to be doing parenteral feeding, if they're going to put in a pacemaker, if they're going to be doing central venous pressure monitoring or central venous sampling. Central venous pressure monitoring is a really quick and easy way to determine the patient's volume level. They can wedge that catheter up against a vessel wall and determine how much fluid they have in the system based on the pressure, the wedge pressure. That's something, of course, that's done at a critical care paramedic level and not something that we do as a paramedic. Complications of medication administration, certainly local at the site, include hematomas, infiltrations, puncturing an artery instead of a vein, and then the development of a thrombus or a clot at the site. Some systemic complications might include an embolism, catheter shear. If you shear off a piece of that catheter, it can become an embolism and get lodged in the heart, the lungs, or the head. And then, as I mentioned, in the external jugular, if you don't tamponade that off before you hook up the IV, you could pull a large amount of air into that opening, causing an air embolism. Intravenous pumps certainly are, just as diverse as the crowds that use them. Intravenous pumps can be used to give boluses, can be used to infuse medications, can be used to piggyback medications into a primary line. Intravenous pumps can also be syringe pumps, where you put medication in a syringe, and rather than just have somebody stand there and bump it, trying to get the medication in over 10 minutes, you can hook it to a syringe pump, and the syringe, you set your volume, the syringe will pump it in over 10 minutes. When we're giving IV bolus medications, make sure that your 6 rights are okay. Make sure that the patient isn't allergic to the medication. You're going to check for infiltration once you start giving the med. Sometimes you might flush the site first with saline and then give your medication and then flush it again with saline so that it gets into the central circulation and does what it's supposed to do. Now, most of the newer IV tubing today has back valves in it. You see that bottom picture, that person has the IV tubing and they've kinked it. By kinking that IV tubing, when you push medication in through that port, back in the day with no check valves, when you push medication into that port, some would go into the vein, but some would go back up into the bag. And it really didn't matter a lot because you're running the IV and the medication's going to get into the patient anyway. but that was a method you used to prevent backflow. Anymore, IV tubing has check valves in them that prevents that backflow, but certainly follow your local practice. IV piggyback medication, that's where you're going to take a second bag. You've got your primary IV established. You're going to take a second bag. You're going to fill it with the drug that you need. You're going to tip it back and forth to dispense the drug in the IV bag. You're going to spike that bag, and then you're going to piggyback it into your primary line through the port. And the only thing you have to be concerned of there certainly is that you can run that through a pump and into the port and let the pump decide the drip rate, or you can manually determine the drip rate yourself using the formula that we talked about. Oftentimes, depending on flow rate and the amount of fluid, if you've got a primary line running, you may shut the primary line off and you may turn on the piggyback and piggyback that in, and then once that's all in, shut that off and start your primary line all over again. You'll see this when you're running blood. The blood will be a piggyback line. You'll have a primary bag of saline. You'll see it with antibiotics. The antibiotics will be a piggyback line. You run the antibiotic in, then you'll shut it off and turn the regular IV back on. Intraosseous infusion, it's not anything new. It's been around since the early 1900s, but with the development of Teflon catheters, starting IVs in the bone just kind of went away. It seemed a pretty aggressive thing to do, a pretty frightening thing to do, to take a big needle and with your hand grind back and forth until you stuck it into a bone. But now with all the new products that are out there, whether you're using the bone injection gun, whether you're using the fast sternal IO, or you're using the easy IO drill, you pretty much can get vascular access in less than 30 seconds. You have a variety of sites that you can use. Probably the most common site for intraosseous is the tibial plateau, 2 fingers below the knee on the big toe side. When we're thinking IO and you're doing an IO in the leg, remember IO to the big toe. On the big toe side of the leg, 2 fingers below the knee, on the very flat part of the tibia, there's a huge area there that you can start your IO in. You also can do 1 finger above the medial malleolus, or 1 finger above your ankle bone in the flat spot of the tibia there. In children, you can use the anterior approach to the femur in children. In adults, we don't do the femur, but you can do the femur in children. You also can use the they're using the tibial plateau, or they're using the medial malleolus in that top one. And then in children, you can also use the iliac spine approach, where you're using the iliac crest to drill your IO in. And again, that's in children. We don't do that one in adults. You can do the humeral heads. You certainly can do the sternum. Sternum is for adults. Humeral heads is for adults. But when it's all said and done, you've got about 8 different sites that you could try on children and about 6 different sites that you can try on adults. To do a pediatric IO infusion, and again, this is something that you'll be practicing in lab. The top picture shows using a hand method where you hand drill it in. I'm sure they have the easy IO drills in class, maybe the bone injection gun, maybe the fast IO, and you'll see an example of different ways that we can gain vascular access. But you need to stabilize the leg. You need to clean the site once you've identified it, and you clean it with whatever you're using to start IVs with. And then you twist this needle back and forth once you puncture the skin. You twist the needle back and forth, back and forth, back and forth, or you use the drill, or you use the bone injection gun, and the needle pulls its way through the bone, and when you feel a pop, you stop. You hook up a syringe, try to aspirate some marrow, and then flush it. And remember this little mantra, no flow, no go. If your fluid cannot be infused, it doesn't push easily, then you're not in the right spot. Just like an IV, no flow, no go. And once you have it flushed, look for infiltration. See if when you flush 10 or 20 mils of fluid in there, look to see if it swells around the IO site. If it does, then perhaps you fractured the bone as you're putting the IO in. And then put some sort of dressing over it. On the ones where you hand drill, they stick up so far that it is important that we put some sort of bulky dressing around it so that people don't bump it and dislodge it. But the easy IOs, they have such a low profile that it's not necessary to put a bunch of dressings over it. The disadvantage of all that dressings, of course, is that you can't see the site. So if the IO infiltrates at a later date, or the IO becomes dislodged because of movement of the leg, you can't see that, and you have to constantly take the dressings off to reassess your site. There's an example of the fast IO system, the fast sternal IO. It's primarily used in the military. The disadvantage to this is that you have one site, the sternum, and it doesn't work well in people who have older people with bone disease, that sort of stuff. It's not for pediatrics. It's for young adults. There's the easy IO with the drill, and again, you'll practice this in lab. There's the bone injection gun. They have both an adult and a pediatric style bone injection gun, and you put the blue or the red arrow down towards the bone. You remove the safety cap off the top, pull that out of there, and when you put a little pressure, a spring inside there just slams that needle right into the bone. Some precautions for all the devices, regardless of what devices you use when you're doing IO. If you can't identify the landmarks, don't be drilling into the bone. If you're aggressive and you push hard, you can fracture the bone. If you don't use aseptic technique, you can get infections in the leg. And if the leg is infected, that's a contraindication to use it as a site. If they've got a sternotomy scar on their chest, they've had their chest cracked to have some sort of heart surgery, you don't want to do a sternal IO there. If they've got a lot of orthopedic hardware, if they've had their knees replaced, that's not a site that you'd want to use. Or if they suffer from severe bone disease or brittle bone disease, doing an IO may fracture the bone. Some contraindications: femoral fracture on the same side, bone diseases, fractures at or above the insertion site, severe burns underlying the insertion site, infection at the site. Using the same bone if you're unsuccessful. You don't want to do that. You want to move over to the other bone. Some possible complications: extravasation of fluid into subcutaneous tissue if you infiltrate, local abscesses, cellulitis, and then an infection of the bone, osteomyelitis. But infection rates with IOs are less than 1%, where if you look at an IV, infection rates anywhere from 17 to 35% infection rates with IVs. Accessing an umbilical vein is not something that we do as a paramedic as well, but certainly in a newborn, they can access the umbilical vein if they need to gain access to the infant's central circulation. When you sever the cord, running through the center of the cord is a larger umbilical vein, and on each side is a small umbilical artery. It's important that what you do here is that you just pass your catheter right into the vein, because it's open and exposed to you. If you pass it too deep, this attaches right to the liver, and you can put your catheter right into the liver and cause liver damage. And certainly if you cath one of the arteries, that can be problematic as well. Fibrinolytics are used to dissolve clots, and when we talk about acute coronary syndromes and strokes and those sort of things, we'll discuss the use of fibrinolytics to help dissolve clots in those vessels. Fibrinolytics must be given before the clot disrupts blood flow, because once the artery is 100% occluded by a clot, or a vein is 100% occluded by a clot, tissue distal to that clot may die. blood transfusions, that's something you can do as a paramedic, because you can run with blood. And sometimes if the blood is not compatible within the first half hour of starting that infusion, let's say they start the infusion in the ED and they put you on the road right away and send you down your way. At least every 5 minutes you're going to be monitoring them for a reaction. Reactions include things like headaches, a change in their level of consciousness, their skin becomes flushed, they may get sick to their stomach and vomit, they may have trouble breathing, they may get a high temp, chills, weak thready pulse, hypotension, go into shock. And in those situations, if you're having a transfusion reaction, you just have to shut the blood off and start the saline. Okay, yeah, immediately discontinue the blood infusion, open the primary IV line, rapidly infuse normal saline, give them some high flow oxygen, and continually monitor them. Contact medical control, let them know what happened, and save that blood bag and tubing, because it's got to be returned back to the lab for analysis to make sure that it was in fact the right type and the right RH factor, and to make sure that it wasn't contaminated as well. Obtaining a blood sample, that's certainly something that we can do as a paramedic, and often it's done while starting an IV. Hooking a syringe to the end of an IV catheter, and then when you puncture that vein, drawing blood back out into that syringe, and then putting it into blood tubes that you can leave in the emergency department so that they can get some baseline values prior to you giving D50 or prior to you giving certain medications. One of the big problems associated with blood sampling, and not very many services do it, one of the problems is hemolyzing the sample. If you're not using an 18 gauge IV catheter, if you're using a 20 or a 22 or a 24, you're using a small catheter in a large syringe, and you're pulling back hard on that plunger and sucking that blood out of that vein, it has a tendency to dice and slice up those blood cells. So it makes it very difficult to get accurate blood counts for your hemoglobin levels and your white counts and those sort of things. All right, in summary then, medication administration is something that you're going to do. Drugs are originally measured to apothecary system, are now based off of the metric system, so we do have to learn the metric system if we haven't already. The household system includes things like droppers, teaspoons, tablespoons, cups, glass, pints, quarts, or gallons, and we express those in Arabic numbers or fractions. We don't use decimals in that particular case because, again, if that point isn't made prominent, if that decimal point isn't made where it stands out, certainly a 1.0 could look like 10. The metric system is used for drug calculation. It's based on a unit of 10. The basic units in the metric system that you're going to have to be familiar with include grams, milligrams, micrograms. We don't do much with meters, but we do a bit with liters and milliliters. There are 4 commonly used units in drug calculations: centimeters, millimeters, micrograms, kilograms. Calculating drug dosages must be able to convert milligrams to grams, grams to milligrams, back and forth. Body temperature pretty much is recorded in Celsius when you're looking at medicine, but we're familiar with the Fahrenheit system and need to learn to use that formula or a smartphone app to convert that. Formulas necessary to calculate drug dosages include the desired dose times the volume on hand divided by the dose on hand. Another formula for drip infusions: the total volume to be infused divided by the total time in minutes multiplied by the admin property set. If you're doing drips not based on weight, the desired dose times the volume divided by dose on hand multiplied by drops divided by milliliters, just a variety of different ones. And while they seem complicated reading them, the more we use them, the more familiar you become with them. And there's only just a couple drugs where we're going to be doing drip rates, and we're going to have to figure this. Now, I should take that back. In adult population, there's not many drugs we're going to use a lot of math with, but in the pediatric population, all their medications are based off weight. So we do have to know how to do some math in those particular situations. The paramedic is authorized to give medications under the direction of a physician, but we do have to follow federal, state, and local laws when it comes to the purchasing, the distributing, the dispensing, and the administration of drugs. So know your local policies and procedures. Know how your drug kit is restocked. Know what drugs are in your protocols, and certainly if you follow protocols and you use the drugs in there, you're going to be okay. It's an issue when perhaps you use a medication outside of your protocol for something different, not covered in a protocol, without medical direction approval. So be familiar with the drugs. Convey important information about the patient to the online physician so they know why you want to give this drug. And not many people have to call online. Most everyone administers medications based off a protocol rather than having to call a physician and get permission. Know your safety protocols and procedures concerning medication administration. Verify your physician's order. Know what you have on hand. Concentrate on the task at hand. Don't get distracted. That's when we start making errors. Position the patient properly. Assemble and correct all your supplies. Handle your drugs really carefully. Avoid dropping and breaking the glass containers they come in. Always use aseptic technique. Be as clean as you can so that you don't cause an infection. Carefully calculate your dosages, and there certainly isn't anything wrong with having your partner double check your dose. Monitor for overdose signs and carefully document what you gave. Follow the 6 rights of drugs administration whenever giving drugs. Use standard precautions every time that you come in contact with a patient. If you're going to be poking a patient, certainly blood may be spilled, and if you're not wearing gloves, you're not wearing proper personal protection equipment, you expose yourself to a potential pathogen. Disinfection involves cleaning the emergency vehicle stretcher equipment with disinfectants, where antisepsis is referring to cleaning the skin. And there's a wide variety of different things that can be used to clean the skin prior to puncturing it with a needle. Sterilization makes an object free of all life forms. It uses extreme heat and certain chemicals. Things come to us with expiration dates. And the reason they have expiration dates is typically that at the end of that expiration date, there's no real guarantee that the product is as potent as it was the day that they packaged it, or the product is not guaranteed to be sterile. Proper precautions should be taken when handling sharps. The number one cause of a significant exposure to a bloodborne pathogen is a needle stick. So self-sheathing needles, needleless systems, not recapping needles with your hand. Those are things that we need to pay particular attention to, especially in a moving ambulance. Medications can be given orally, rectally, through a G-tube, rubbed on the skin, can be inhaled, injected, can be given through vascular access or through the bone. Blood samples, can be done, and some services are doing that prior to giving medications. And that ends the section on medication administration. So if you've got any questions, you know how to get a hold of me. So with that, I'll talk to you soon. Bye.